Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
This program is presented by Medscape Education Global.
Hello, I'm Dr. Carolyn Lam, Senior Consultant Cardiologist from the National Heart Center and Professor at Duke National University of Singapore. It is my pleasure to welcome you to this program entitled The Evolving Role of Nonsteroidal Mineralocorticoid Receptor Antagonists, or MRAs, for Heart and Kidney Disease. I am delighted to be joined by key faculty experts in heart and kidney disease and trials, and they are Dr. Janani Rangaswamy, Dr. Muthu Vadaganathan, and Dr. Brendan Nguyen. We will discuss the rationale for cardio-kidney benefits with the MRAs. We will also be focusing on the evolving evidence for both heart and kidney protection, as well as practical considerations for the clinical implementation of key clinical trial results. So let's get started. Let's talk about our understanding of the mineralocorticoid receptor. Now, for years, we have understood that receptor to be primarily involved as a promoter of sodium and fluid retention and potassium excretion in the kidney. And so for a long time, MRAs, or antagonism of that receptor, was seen as a way of getting rid of sodium, but potentially keeping potassium, so like a potassium-sparing diuretic. Now, our understanding has increased greatly, and we now know the mineralocorticoid receptor is involved not just in the kidneys with sodium handling and fluid handling, but also plays a key role in fibrosis in both the heart and the kidney, and in fact has a key role in the generation of what we now call the cardiac kidney metabolic syndrome. And so when we talk about MR antagonism now, it's not just talking about the heart alone or the kidney alone, but both. You see, mineralocorticoid receptor overactivation is a key driver of that vicious cycle of heart and kidney disease that eventually culminates in fibrosis, dysfunction, chronic kidney disease, and heart failure. And so we, of course, would like to address both organs in breaking this vicious cycle. Now, starting from the heart failure world, the MRAs, including spironolactone and eplerenone, have been long established as one of the pillars of heart failure with reduced ejection fraction treatment. And we know this from famous trials like the RAILS trials and the Emphasis trial, showing that these compounds, spironolactone and eplerenone, actually improve outcomes in these patients with HFrEF. However, despite being a class 1 recommendation for patients with HFrEF, we also know that there is a great underutilization of MRAs in heart failure with reduced ejection fraction throughout the world. Now, is this because of side effects? Is this because we just need better clinical implementation? Well, that's for HFrEF alone. How about with heart failure with preserved ejection fraction or ejection fraction 40% and above? Well, we now know that this form of heart failure is now the predominant type of heart failure in aging societies and is associated with very poor prognosis and repeated hospitalizations similar to hospitalized HFrEF. Now, there is perhaps an even more urgent unmet need in this class of a heart failure because we don't have the other pillars of medication until recently. But what evidence do we have that mineralocorticoid receptor antagonism may help in HFpEF? Well, we do have lots of evidence that the comorbidities associated with HFpEF, such as hypertension, obesity, diabetes, are associated with increased aldosterone. We also have preclinical studies, and I have to share about one that I was personally involved in when I was training. And it was a model of HFpEF known as a DOCA model. And we've seen that when you give this aldosterone stimulation associated with pressure overload, these mice and small animals have even more diastolic dysfunction and evidence of HFpEF. Now, have we tried antagonizing the mineralocorticoid receptor in HFpEF? Indeed, we have with the TopCat trial. Unfortunately, this trial, which randomized patients with HFpEF to spironolactone or placebo, was neutral in its primary outcome. There was some hope, though, because we found that there was regional heterogeneity that may have impacted the overall trial results, where it was patients in North America, for example, where they seem to have a more sure form of HFpEF with raised natriuretic peptides and so on that appeared to benefit from spironolactone. Now, because of this, and because we now are even evolving in our understanding of the mineralocorticoid receptor and have even perhaps more specific agents, I think it is time that we look at again this question of whether mineralocorticoid receptor antagonism may be beneficial in HFpEF. So as opposed to the steroidal MRAs like spironolactone, finerenone is a non-steroidal MRA. It has shown to be more selective for the mineralocorticoid receptor, has a shorter half-life, and a more balanced distribution between the heart and the kidney, therefore potentially having benefit with perhaps a better tolerability profile. All this, of course, needs to be tested in the trials that you will hear about as the program continues. First, let me, though, paint a big picture of the programs that you are going to hear about. First of all, you will hear about the Fidelio and Figaro trials, and these are trials focused on patients with type 2 diabetes and chronic kidney disease across the entire spectrum of kidney disease and looking at both a kidney and heart outcome. And these two separate trials are combined in a pooled data analysis called Fidelity. And this is a huge, huge program, one of the largest of patients with diabetic kidney disease. You will also hear about the Fine Arts heart failure trial. And this is that trial of finerenone versus placebo in patients with HFpEF. And finally, an overarching program, we have combined the patients from Fine Arts, Fidelio, and Figaro to look at them across the totality of the cardiac kidney metabolic syndrome called Fine Heart program. So, are you ready to hear about the results and learn about the clinical applications? I hope so. And please continue to the next chapter first to learn from Dr. Rangaswamy about the evolving evidence related to kidney protection with nonsteroidal MRAs in the setting of diabetes. Thank you for listening.
Hello, I'm Dr. Janani Rangaswamy. I'm a nephrologist with expertise in cardiovascular kidney medicine. I'm also a professor of medicine at the George Washington University School of Medicine. And today, I am here with you to present the latest evidence relating to kidney protection in diabetes. But first, let's pull back and look and appreciate the magnitude of the problem that we are trying to solve. When you look at the global burden of diabetes, which is in over 500 million individuals worldwide, largely type 2 diabetes, type 2 diabetes in itself is a driver of about half of all chronic kidney disease that we see. But what is so important to appreciate here is while kidney failure is the dreaded outcome of progression of kidney disease with diabetes, even before individuals hit that point of kidney failure, 90% of them will either have an adverse cardiovascular event or even die prematurely before they hit that endpoint of kidney failure. So, this competing risk is so important to appreciate as we provide holistic care for our patients with type 2 diabetes and chronic kidney disease. But if we think about the problem, it's even more than just the type 2 diabetes and chronic kidney disease. We have to actually go a little more upstream and upstream to a large portion of the overlapping cardiovascular, kidney, and metabolic conditions, or the CKM syndrome as recently defined by American Heart Association. Excess and or dysfunctional adiposity is upstream to a lot of those pathophysiological processes and that central milieu of inflammation, oxidative stress, vascular dysfunction, and insulin resistance that is just such a common theme across these conditions. That excess and or dysfunctional adiposity also increases the risk for risk factors like hypertension, dyslipidemia, metabolic syndrome, and diabetes, which further add fuel to that fire. Ultimately, then increasing the risk for adverse kidney outcomes, as in kidney failure, or adverse cardiovascular outcomes. Now, separate from that upstream targeting that we talked about, even between the kidneys and the heart, there's further this bidirectional organ crosstalk, and all of this happens in CKM conditions on the backdrop of neurohormonal activation, such as through the RAS and the sympathetic nervous system, as well as disturbances in hemodynamics and volume. Now, this is so central to our practice as nephrologists, but it has relevance even outside of nephrology. This is the KDIGO risk grid. And here you see grades of increasing albuminuria from A1 to A3 and declining GFR all the way from G1 through G5. And what you can appreciate here is as GFR declines and albuminuria increases, the overall risk for adverse kidney outcomes increases. And that is what you typically see in this risk grid. But when you extend what this risk grid can also do just with that GFR and UACR, this is a really nice paper from the CKD Pooled Cohort Consortium showing that declining GFR and increasing albuminuria also have predictive value for other important clinical outcomes ranging from all-cause death, hospitalizations, both cardiovascular and all-cause, and a whole spectrum of cardiovascular phenotype outcomes, such as ASCVD, such as heart failure. These are such important details when we consider that, again, coming back to the holistic care for both cardiovascular and kidney outcomes in individuals with type 2 diabetes and CKD. And this is the premise, therefore, if you now look at this really nice pyramid figure from the KDIGO 2024 guideline, foundational to all the other steps first is one, assessment of kidney failure risk using standardized, validated equations, and importantly, side by side, cardiovascular risk assessment using standardized and especially validated equations that also represent how kidney disease itself is involved in that causal pathway to cardiovascular disease. And remember, a lot of that risk assessment should ideally commence outside the domain of nephrology in primary care to start with. So, a lot of these pathophysiological underpinnings are really nicely reflected across societal guidelines, and there is high level agreement in the overall approach to that holistic care. There's a lot of emphasis in the KDIGO CKD document itself on first how to screen in for chronic kidney disease. So it's so important to understand that both for GFR and for albuminuria as assessed by your urine albumin to creatinine ratio, or UACR, there must be a persistent decline in EGFR. Keyword here, persistent, so that there's at least two measurements 3 months apart for GFR less than 60 cc's per minute. Same for albuminuria, because there can be variability in both these markers. So transient ups and downs don't count as chronic kidney disease, so that demonstrating that chronicity is so important in establishing that the individual has chronic kidney disease. So there's a lot more that you can learn from this document in the supporting text. Again, screening in and also for risk assessment and stratification, both using EGFR and UACR across all relevant specialty guidelines are really given prominence. And in higher risk individuals, those individuals with those lower EGFR strata and higher albuminuria strata, even more than the usual annual frequency screening is important, especially considering that any additional residual risk, for both kidney events and cardiovascular events can be mitigated, especially with understanding how much residual albuminuria the patient still has, just given that we have this whole, armamentarium of therapies that can be used to reduce albuminuria. When you look again at that holistic approach to managing patients with type 2 diabetes and kidney disease, first and foremost, there is that emphasis on lifestyle. It is on that healthy lifestyle, which includes both healthy diet, physical activity, smoking, cessation, and weight management, that all the other principles and pharmacotherapies that we're about to take a look into will fit into. So it has to be in tandem. It's not one or the other. And from a nephrology perspective, you really can't say enough about the importance of that healthy lifestyle as that foundational step. And then you see there is guidance for blood pressure targets, and ideally to reduce that risk, as you can see here, systolic blood pressure of less than 120 with priority for RAS inhibitor use, especially in the albuminuric individual as first line to achieve that goal, especially with concomitant hypertension. You also see that SGLT2 inhibitors are put in as first line therapies. And it's important to recognize that while generally you'll see one therapy used after the other, these therapies are first line with broad overlap and inclusion criteria. What we're also beginning to understand is most of all these foundational classes we're talking about actually have some common pathways, but also independent effects. And a lot of the benefits are likely additive, meaning you can still accrue benefit whether an individual is on a different foundational class of therapy or not. Then you see more guidance that is provided in those with resistant hypertension, for example, the use of a steroidal MRA, or in those where additional glycemic control is necessary, where a GLP-1 receptor agonist can be utilized or co-utilized. And there's also language for nonsteroidal MRAs based on data from the pivotal trials that we're going to look at in a minute. Again, this is from the ADA EASD consensus guidance. Again, what is highlighted here is that early on approach to one risk stratifying, identifying that individual with kidney disease, and then starting upfront with RAS, SGLT2, and or GLP-1 receptor agonists, and the consideration of the MRA class. Now let's take a little deeper look at the nonsteroidal MRA finerenone. And here you're looking at two sister trials, Figaro and Fidelio, enrolling individuals with type 2 diabetes and chronic kidney disease. And Figaro, as you can see, the composite primary endpoint is cardiovascular. And in Fidelio, it is kidney, with the key secondary endpoints being the mirror image thereof. So common population, very, very large complementary trials, some overlap, in the inclusion criteria, one with a cardiovascular endpoint and one with a kidney endpoint. This is another figure showing the fidelity pooled analysis where you're looking at individual level data from both these trials. And this is a fairly high risk population, as you can see, with a baseline UACR of over 500 milligrams. Very, very consistent benefits seen for the primary cardiovascular outcomes, hospitalizations for heart failure, kidney failure requiring kidney replacement therapy, and the kidney composite outcome. And so, there are some limitations in that this pooled analysis did not include individuals with non-albuminuric kidney disease, for example, and also a full, diverse representation, and particularly of Black patients, was not achieved in this pooled analysis. However, importantly, this is also relevant to that type 2 diabetes and CKD population, and more information will follow as to whether that can be extended to individuals without diabetes. In the fine heart pooled analysis, to that fidelity analysis, we now have data added from FINE-ARCS, which is the trial with heart failure with preserved ejection fraction and finerenone versus placebo. Again, the totality of evidence across all these overlapping CKM conditions is fairly consistent. And here, in the secondary endpoint, you even see a 9% relative risk reduction for all-cause death. I'm just going to briefly emphasize that there are some physical chemical differences between the non-steroidal MRA and the more traditional steroidal MRAs, with finerenone having a shorter half-life. Some of the active metabolites generated on the steroidal MRA side do not happen in finerenone, and this may be some of the differences we see with the overall lower rates of hyperkalemia and also urgent hyperkalemia. The blood pressure effect is also more pronounced with the steroidal MRA side than on the nonsteroidal MRA. In fidelity, again, finerenone increased hyperkalemia as expected with the class, but the clinical impact as to whether the drug needed to be de-escalated or discontinued altogether or needed an urgent intervention was truly minimal, as you can see, in less than 1%. When you look at SGLT2 inhibitors, now everyone is familiar with the whole suite of SGLT2 inhibitor kidney trials, starting from the first one, Credence, now all the way to EMPA-KIDNEY and DAPA-CKD in between. Now extending the evidence base that we have outside of diabetes, including in CKD without diabetes, also representing a whole range of other glomerulopathies like IgA nephropathy and FSGS. All of these are well represented without any heterogeneity by that etiology towards the benefit for the primary and the secondary outcomes. The overall real world evidence also supports that the general safety profile of these agents is overall quite good. Common side effects include genital infections, urinary tract infections, and certainly when we co-utilize therapies, especially in that diabetic individual with kidney disease, attention to glucose and hypoglycemia is also very important. A couple of words about the confidence trial that everyone is very excited about that we'll report soon. So now we looked at finerenone, we looked at the SGLT2 inhibitor body of data. What happens when you put them together? Is it safe? And importantly, is there any benefit or efficacy that will be seen? So this is a trial recruiting over 800 individuals to global trial across 13 countries in individuals with type 2 diabetes and kidney disease, also a high risk population, with a UACR, again, a little over half a gram in these individuals. And here you see there are three arms. There's finerenone with empagliflozin, or individuals get randomized to finerenone plus placebo, or empagliflozin plus placebo. The primary outcome is a change in UACR from baseline to 6 months, so that 180-day mark. But so important, we for the first time will also understand the safety data. What happens to blood pressure? What happens to potassium? What happens to changes in creatinine? And in this new era of combination therapies, these are the burning questions in the minds of nephrologists, cardiologists, endocrinologists, and internists. Again, these are, again, from the baseline confidence data. You can see a diverse representation of populations, 46% Asian, 8% African American. Over a quarter of individuals randomized had coexistent ASCVD, but only 4% with heart failure. Near full enrollment with baseline ACE or ARB, and a quarter of individuals, interestingly, at baseline also had concomitant GLP-1 receptor agonist inclusion. Now, speaking of the GLPs, The FLOW, the pivotal trial that we have for semaglutide in patients with chronic kidney disease, reported some really impressive results for benefits for the primary kidney composite and all the pre-specified hierarchical secondary outcomes for cardiovascular disease, and importantly, even an all-cause mortality benefit, which is truly impressive. The signal is also consistent from the analysis of the kidney, the 5-point kidney composite from SELECT, which was the cardiovascular outcome trial in individuals without diabetes with semaglutide. And as you can see for the kidney outcomes, the outcome is largely driven by reduced incidence of new onset albuminuria. So we're truly in this era of multi-pillar therapy with foundational classes including RAS inhibitors, SGLT2 inhibitors, nonsteroidal MRAs, and the GLPs on that backdrop of healthy lifestyle as well as lifestyle modification. So this is all we have here for me, and we will now hear it next from Dr. Vaduganathan about evolving evidence for cardiovascular protection in heart failure. Thank you so much for your time.
Hello, my name is Muthu Vaduganathan, a cardiologist at Brigham and Women's Hospital and Harvard Medical School, and welcome back to this chapter on the evolving evidence of cardioprotection with the non-steroidal mineralocorticoid receptor antagonist finerenone in heart failure with and without diabetes. The non-steroidal MRA finerenone was recently studied in the pivotal Fine Arts heart failure trial. Fine Arts heart failure was a global investigation across many countries involving 6,001 participants with established heart failure with mildly reduced or preserved ejection fraction, and tested the concept whether the addition of finerenone to standard of care was better than placebo in lowering the risk of the primary endpoint of cardiovascular death and total heart failure events. A number of key secondary endpoints were also collected, including measures of quality of life and kidney-related outcomes, as well as mortality. The primary results, which many of you may have already been aware of, showed that finerenone reduced the risk of this primary outcome by 16%. This benefit was seen very early and with continued separation of curves with a meaningful absolute rate reduction of about 3 per 100 patient years. Finerenone in the Fine Arts heart failure trial really sits at the intersection of the preceding clinical trials of type 2 diabetes and chronic kidney disease. In a pre-specified manner, the FineHeart pooled analysis brought together the evidence of finerenone across these 3 phase 3 pivotal randomized clinical trials. And in taking now the totality of evidence of those 18,000 participants enrolled across these 3 trials, we see that finerenone reduced a number of key mortality, kidney, and cardiovascular events. And we'll take a deeper dive into some of these intersections using secondary analyses from the Fine Arts heart failure trial reported since the primary publication. Now, ultimately, we know that patients with heart failure often don't have heart failure alone and may have multiple morbidities. They may have coexisting chronic kidney disease or diabetes, or certainly at risk for developing them in the near term. And so the effects of a therapy on not just heart failure status, but also on adjacent conditions is of top priority for clinicians worldwide. So in secondary analyses of the Fine Arts heart failure trial, we learn a number of aspects of how finerenone not just affects the heart failure axis, but can affect this global paradigm of cardio-kidney metabolism. In the Fine Arts heart failure trial, we found that finerenone robustly reduced the rates of albuminuria, and here you see a 30% reduction by just a month to 6 months of therapy. This was sustained throughout the duration of follow-up, and importantly, many of the patients enrolled in Fine Arts were at low kidney risk. They had low levels of albuminuria at baseline, so this therapy prevented the new onset of albuminuria during follow-up. And this is new onset micro or macroalbuminuria, and reduced it to a substantial degree. So finerenone may provide an axis of kidney protection in patients with established heart failure. Furthermore, we learned the effects of finerenone, which was thought to be a heart failure or kidney-related therapy, on metabolic function. And in fact, we found that finerenone reduced the risk of new-onset diabetes. While finerenone doesn't have immediate glucose-lowering properties, there was no between-arm differences in hemoglobin A1C that was meaningful. You can see here there was a reduction in new-onset development of diabetes during the course of the trial, or new need for antihyperglycemic therapies, and this might be related to the systemic benefits of this therapy, including in altering systemic and end organ pathways of fibrosis and inflammation. Furthermore, we found that finerenone was beneficial across a range of obesity status and BMI. In fact, there were hints that obese patients with HFpEF, a critical group of patients which has had growing interest worldwide, may even benefit to a greater degree with a therapy like finerenone. Additionally, we find that finerenone may affect cardiovascular events beyond heart failure alone. In fact, at the American College of Cardiology 2025 meeting, there were new data presented that finerenone reduced the risk of new-onset atrial fibrillation. And this was based on the FIND-HEART pooled analysis of the 3 pivotal trials. And there was a 17% reduction in the new-onset development of atrial fibrillation during the course of these trials. This was consistent in patients with heart failure or chronic kidney disease and type 2 diabetes, and was a robust risk reduction. So providing global protection, not just against heart failure clinical progression, but also on other events such as new onset atrial fibrillation. So we've also learned from secondary analysis about how finerenone can be positioned in clinical practice of patients with heart failure. For instance, patients with heart failure we interact with in a number of clinical settings, whether in the hospital setting or in the post-discharge window or in outpatient ambulatory clinical care. And the Fine Arts Heart Failure Trial allowed enrollment of each of these pathways of patient interactions. And patients were enrolled whether they were hospitalized or in ambulatory care. And in fact, the relative risk reductions with finerenone were seen irrespective of that site of randomization or the site of implementation. But those patients who we meet in the hospital who are hospitalized for heart failure are really our highest risk patients for disease progression. And in fact, the absolute risk reduction or the treatment gains with finerenone were in fact magnified in this in-hospital setting. Furthermore, we know the drug works extremely rapidly. You saw there that the curve separated very quickly, and in fact, first statistical significance is seen within just 1 month of randomization for the primary composite outcome, and this too was seen in terms of health status benefits. Patients are able to feel better quicker on a very rapid timescale, and in fact, in just months of initiation, there were curve separation in terms of Kansas City Cardiomyopathy Questionnaire improvement or a validated health instrument about how patients are functioning and feeling in their daily lives with heart failure. Furthermore, standard of care has rapidly evolved recently with HFpEF, and SGLT2 inhibitors have been strongly guideline recommended since the initiation of the Fine Arts Heart Failure Trial. And there were about 13 to 14% of patients, or about 800 patients, in the Fine Arts Heart Failure Trial that were previously treated with an SGLT2 inhibitor, and reassuringly, the benefits of finerenone were seen irrespective of whether you were or were not on an SGLT2 inhibitor, suggesting these are really complementary domains of risk reduction, and these therapies can be effectively used together to provide optimal and global risk reduction. So to conclude, I hope that these data have provided some additional context of how finerenone affects heart failure care. We've already learned about their effects in type 2 diabetes and chronic kidney disease. And here we see finerenone rapidly improves clinical events, also improves various dimensions of health status on the days to month scale. And those treatment benefits were seen across all clinically meaningful subgroups, including patients already on standard of care therapies such as SGLT2 inhibitors, and importantly, finerenone, while developed as a kidney disease therapy or a heart failure therapy, really sits at the nexus of cardio-kidney metabolism and affects multiple domains of cardio-kidney metabolic health and can even prevent new onset diabetes and new onset albuminuria, as was seen with recent data with the Fine Arts Heart Failure trial. So this global evidence, from the initial publications to learnings from these secondary analyses, really position finerenone as a key implementation strategy to further reduce risk in these patients with heart failure with mildly reduced or preserved ejection fraction, and with appropriate monitoring can be safely implemented alongside standard of care therapies in this high-risk population. It's my pleasure to introduce my next colleague, Dr. Brendan Nguyen, who will present a real clinical case to illustrate the practical considerations around the use of nonsteroidal mineralocorticoid receptor antagonists in your own clinical care. Thank you so much for listening.
Hi everyone, I'm Brendan Nguyen. I'm a nephrologist from Sydney, Australia, dedicated to translating research into improved patient outcomes through my work leading clinical trials and consortia in the cardio-kidney metabolic space. Now, we've heard from my colleagues, Dr. Lam, Dr. Vadaganathan, and Dr. Rangaswamy, about the latest evidence for non-steroidal MRAs in heart failure, kidney disease, as well as updated clinical practice guidelines. And today, I'm going to be putting that into practice by walking you through a case to illustrate the implementation of non-steroidal MRAs like finerenone into practice in the clinic. So this is a case I'm presenting based on one of my own patients. You can see that she's 75 years old and she has chronic kidney disease and type 2 diabetes. Her comorbidities are listed here. Importantly, she not only has kidney disease, but has heart failure with preserved ejection fraction, coronary artery disease, atrial fibrillation, and obesity. So a constellation of comorbidities that is very typical of cardio-kidney metabolic syndrome and very common in practice. And you can see her medication list when she was referred to me on the right-hand side. A long list that, again, is very typical of a patient with this constellation of comorbidities. Of note, you can see that she's on an SGLT2 inhibitor, empagliflozin. She's anticoagulated with apixaban. From a kidney and heart failure point of view, she was on maximum dose of a RAS inhibitor with ramipril 10 milligrams once daily, and a range of other medications, including a loop diuretic and insulin for type 2 diabetes. When she was referred to me, you can see her laboratory data here, and I'll just point out a couple of key pieces of information. Her serum creatinine was 135 micromoles per liter with a corresponding GFR of 33 mils per minute per 1.73 meters squared. Her potassium is 4.9 millimoles per liter, so within normal range. HbA1c 7.8%. And importantly, she has severely increased albuminuria with a urine albumin to creatinine ratio of 526 milligrams per millimole. So this is a woman who, despite RAS inhibition and an SGLT2 inhibitor, is at very high risk of not only kidney disease progression, but cardiovascular events, hospitalization, and mortality. Now, she's relatively frail, but still living at home. She has supportive children nearby. And her blood pressure is 138 on 76 millimeters mercury, BMI is 31, and she's close to euvolemic with only some trace lower limb edema. Now, this is the kind of patient who I would consider for starting a non-steroidal MRA. She has clearly a number of cardio-kidney metabolic conditions, including heart failure with preserved ejection fraction and chronic kidney disease. And importantly, she has severely increased albuminuria, over 300 milligrams per gram. And that would place her at elevated risk despite optimal treatment with a RAS inhibitor and SGLT2 inhibitor. So the key thing to recognize when starting a non-steroidal MRA is what's the serum potassium and what's the GFR. This particular patient, you can see her serum potassium was 4.9, so less than 5, and her GFR was greater than 25. It was 33 mils per minute. So she is an ideal candidate for a non-steroidal MRA like finerenone. Now, when starting a nonsteroidal MRA, the important thing to recognize is that serum potassium needs to be monitored periodically to reduce the risk or mitigate the risk of hyperkalemia. The key values to know are 4.8 and 5.5. And you can see that if the serum potassium is less than or equal to 4.8, finerenone can be increased to the target dose of 20 milligrams. If the serum potassium is between 4.9 and 5.5 millimoles per liter, the dose should be maintained. And if hyperkalemia does occur with a serum potassium greater than 5.5 millimoles per liter, then treatment should be temporarily withheld, hyperkalemia be managed appropriately, and treatment be restarted when potassium has normalized. What you can see here is that once finerenone is started, typically at a dose of 10 milligrams a day for those with a GFR less than 60, those are the types of patients I routinely see in practice, then serum potassium should be monitored for approximately 4 weeks after treatment initiation, and finerenone can be dose adjusted to up to 20 milligrams if serum potassium is within the normal range, maintained at a 10 milligram dose, or can be temporarily withheld if hyperkalemia ensues. So, what happened in this particular case? You can see that she returned to see me 4 weeks after treatment initiation. She was well, she was euvolemic. Blood pressure was, if anything, a little bit better at 132 on 75 millimeters of mercury. Serum potassium was 5.1 millimoles per liter, so up by zero point 0.2 millimoles per liter. Creatinine had increased and GFR had dropped from 33 to 28 mils per minute. And what did I do in this case? Well, we do have guidance from KDIGO, and I've listed it here. And what that tells us is that for drugs with hemodynamic mechanisms of action like MRAs, SGLT2 inhibitors, RAS inhibitors, we should tolerate small GFR reductions up to 20 to 30% because these are expected and a sign that the therapy is working. And we should avoid temporary drug discontinuation for small changes in serum potassium or creatinine wherever possible. So we continued therapy in this case. And those guideline recommendations are reinforced by data from the Fine Arts HF trial. And what you can see on the left hand panel is that in the blue line, the people who do the worst are the people who are allocated to placebo and have an acute GFR dip. But if you're allocated to finerenone and you have an acute GFR dip, you tend to do better. And on the right hand side, you can see that regardless of the acute change in GFR, which is displayed on the horizontal axis, patients who are randomly allocated to finerenone tend to do better than those allocated to placebo, regardless of the acute GFR change. So that certainly supports the practice of not discontinuing therapy automatically or reflexively if there is an acute reduction in GFR. The same is true for serum potassium, and these are also data again from the Fine Arts HF trial that showed baseline serum potassiums at month 3 on the horizontal axis and the event rate for the primary outcome of heart failure or cardiovascular death on the y-axis. And what you can see is, regardless of the serum potassium level achieved, patients allocated to finerenone tend to do better. So again, the consistent message is there may be changes in serum potassium or GFR, but these should be expected as a part of a mechanism of action of the nonsteroidal MRA, and we should avoid reflexively discontinuing therapy for small changes in these biomarkers wherever possible. Now, we also have data, and I remind you that the patient case that I showed was someone on an SGLT2 inhibitor. We have data from clinical trials now that demonstrates that these medications also reduce the risk of hyperkalemia. This is a collaborative meta-analysis that I led about 2 years ago of the SGLT2 inhibitor trials. And what we found was that SGLT2 inhibitors reduce the risk of serious hyperkalemia defined as a serum potassium greater than 6 millimoles per liter by about 16% overall. And that effect is consistent across a wide range of subgroups. And so there's certainly several lines of evidence now that suggests that wider use of SGLT2 inhibitors will enable better use of finerenone by reducing the risk of hyperkalemia. We're moving now to an era of multiple highly effective therapies, not only for slowing kidney disease progression, but also preventing cardiovascular events, particularly heart failure for patients with chronic kidney disease. We now have 4 pillars of therapy for chronic kidney disease with diabetes: RAS inhibition, SGLT2 inhibitors, nonsteroidal MRA, and more recently, the GLP-1 receptor agonist semaglutide. What we know is that if we use these medications in combination, we can substantially improve outcomes for our patients: cardiovascular outcomes, kidney disease outcomes, as well as all cause mortality. And for a typical patient in middle age who is at risk of cardiorenal metabolic complications, we've seen that combination therapy is projected to extend, in this case, kidney disease event free survival by at least 5 years, with similarly substantial benefits for cardiovascular and mortality outcomes, underscoring the need to really implement these therapies to benefit our patients as soon as possible. Finally, drawing upon our experience from the heart failure literature, with these multiple highly effective therapies, one of the challenges will be, how do we implement these therapies as quickly and safely as possible for those patients with kidney disease? And whilst we're just at the start of this conversation, there is much more work to be done to reduce clinical inertia and implement all of these therapies, including nonsteroidal MRAs, as soon as possible to maximize their cardio-kidney benefits for our patients. So that's all from me today. As you can see from the data, erinone is a really important addition to our therapeutic armamentarium across the spectrum of cardio-kidney metabolic conditions. With a clear understanding of patient selection, initiation, and monitoring, we can confidently, effectively implement finerenone in routine practice. This approach will translate to meaningful benefits and better outcomes for our patients with cardio-kidney metabolic disorders. Thanks very much for participating in this activity. Please continue to answer the questions that followed and complete the evaluation. Thanks for your attention.
This program was presented by Medscape Education Global.